Now, the second question that they asked was comparing opioids versus IV acetaminophen, also called APAP or Ofirmev, OFIRMEV, I believe is how the IV acetaminophen now comes, the generic form, I'm pretty sure. But they suggest in favor of IV acetaminophen over IV opioids alone for the initial management of moderate to severe pain in the pre-hospital setting if IV acetaminophen is available, affordable, and easy to administer. Now, it is available, it is affordable, it's not particularly easy to administer to children, and I can explain why here in a minute. Now, the recommendation is in favor of IV acetaminophen over IV opioids alone. Okay, they're not advocating for IV acetaminophen for moderate to severe pain in isolation. Okay? It's a combination, and very rarely it's going to be very difficult to completely get rid of having to give IV opioids. I know that would be the ideal situation, if possible. But if you can decrease how much you use, then I think that it is a win. You would still decrease the side effects because you're not giving as large of a dose of IV opioids as you would compared to, say, given the combination of IV acetaminophen and opioids or IV Toradol and opioids. Now, IV acetaminophen generally comes in a glass bottle. So that means you have to use what kind of IV tubing? That's right, vented. So you have to have a vent on it. Now, there are some dosing considerations. It's not especially difficult to dose IV acetaminophen because the IV dose of 15 milligrams per kilogram is the same as our oral dose, 15 milligrams per kilogram, with a max of 1 gram. And the same considerations on not giving acetaminophen if they've had it, I believe, in 6 hours, or more than should be 4 grams in the last 24 hours. Let me fact check that. Yes, that's right. So if they haven't had IV acetaminophen in the last 6 hours, or more than 4 grams in a day, then you can consider IV acetaminophen. Now, if the patient is under 50 kilograms and you're wanting to give them IV acetaminophen, it becomes more difficult because you can't give the full gram. You can't give the full gram. If they are more than 50 kilograms or higher, you can administer the full gram. Okay. Now, we cannot just hang the drip in its original container and give whatever dose we want, all right? Because you risk administering too much IV acetaminophen and giving, a toxic dose. So if the patient's over or less than 50 kilograms, you'd have to draw that out, okay, in a syringe, give it via syringe pump, or mix it in another bag, and then administer the whatever bag you put it in, whether it's a 100 milliliter bag or a 50 milliliter bag. But here's the thing: if you're given IV acetaminophen to children who get substantially lower volumes of fluid, and you're taking a volume of acetaminophen, mix it in a additional in a bag, a separate container to administer, then you might give too much volume. So it's almost a no-win situation trying to give IV acetaminophen to children. It's complicated, and many places just give it to patients who are 50 kilograms or higher because they don't have to. It's just not as difficult to administer, And kids respond generally pretty well to oral acetaminophen or oral NSAIDs. So, IV acetaminophen should be given over 15 minutes. Why 15 minutes? Because it's kind of arbitrarily defined. That was the study protocol when they tested IV acetaminophen against other medications, including opioids. And then there was one study I found that says if you give it fast, there are no adverse events. So the rule of thumb is give it roughly over 15 minutes. Don't give it too fast. Don't give it too fast. So some other considerations with IV acetaminophen. Obviously, it can hurt the liver. That's what happens if they have acetaminophen toxicity. Okay, it's contraindicated if they have severe hepatic disease, so hepatic insufficiency or active liver disease. All right, there are very few side effects if you give the right dose and you don't give too much of it. Also, when it comes to IV acetaminophen versus NSAIDs or Toradol, when giving Toradol or NSAIDs, we're worried about platelet aggregation, platelet function. You don't have to worry about that with IVs. Now, you might say, well, why don't we just give oral acetaminophen? So, IV acetaminophen has a more rapid and predictable onset, usually 5 to 10 minutes. All right. It peaks at around 15 minutes compared to rectal or oral acetaminophen. The onset orally is roughly anywhere from 10 to 60 minutes or longer, depending on the patient. But a lot of studies of perioperative pain, so pain before operations, saw a similar efficacy. All right. But there are patients who cannot take oral medication. So the too long didn't read version is there's probably little benefit to giving it IV over oral if the patient can take oral acetaminophen. All right, little benefit. However, we are accustomed in EMS. We give a lot of opioids. We give ketamine. We're accustomed to seeing more immediate effects. And that has we've become sensitized to that. And now we expect immediate effects. It's like when we transitioned from giving IV naloxone primarily when we didn't have the intranasal route available to us. If you've been an EMS provider long enough to remember when we did that, compared to giving intranasal naloxone, when we switched from IV to intranasal, it was taking forever, and we thought it's not working, so we would give more, and we would give more, and before you know it, we gave 4, 6, 8 milligrams of intranasal naloxone. And now we know that all we have to do is be a little patient, wait a little while longer for it to take effect, and it's going to be the same thing with IV versus oral acetaminophen. Now, obviously, if it's not too difficult to administer the IV acetaminophen, right? If it's already pre-mixed, comes in a glass vial, I just use the right tubing, I spike it, I prime my line, connect it to IV, and I give it roughly over 15 minutes. If I can start seeing that effect in about 15 minutes, and let's say I have initially given an opioid, I've got the patient's pain under control, so then I administer my IV acetaminophen, then hopefully by the time that opioid starts wearing off, the IV acetaminophen should start working. Theoretically, that's how I think about this, and I think that's one of the benefits to IV acetaminophen. Okay, so just to close the loop on IV acetaminophen, I know that we've talked about it a lot. Remember, no Tylenol if it's been taken within the past 6 hours. max of 4 grams per day. Full dose is only the full dose, which is 1 gram, is only for is only for patients who are 50 kilograms or greater. Also want to use it with caution in patients with hepatic disease and any patient who will not be able to properly process the Tylenol in their liver. So chronic alcoholism, chronic malnutrition, severe hypovolemia, or severe renal impairment. Now, guidelines do give some other recommendations. They do suggest also IV NSAIDs over IV opioids for the initial management of moderate to severe pain. They do slightly favor IV NSAIDs over IV acetaminophen. They also recommend PO NSAIDs or PO acetaminophen for the initial management. So it's kind of all the recommendations are favoring either IV non-opioid management or PO non-opioid management for the initial management. There's a conditional recommendation for IV NSAIDs over IV acetaminophen because there's one study that found a higher pain severity score at 15 minutes with IV acetaminophen compared to IV NSAIDs, but the remaining evidence didn't demonstrate a significant difference at 30 or 60 minutes. To reiterate, a multimodal approach is greater than a single opioid. It's a better model of pain management, and it's based on a biological, psychosocial model using several techniques, each acting at different sites along the pain pathway. It reduces dependence on a single medication, a single mechanism, and it might reduce, possibly eliminate the need for opioids. Now, our goal is not to totally eliminate the needs for opioids, but it might eliminate the need in some patients. But at the end of the day, it should comprise of shared decision making, right? With the patient expectations and educations. The patients need to understand, and you have to explain to them that the goal is not the total absence of pain, but rather an acceptable level of pain that allows them to achieve functional goals. So, our goal shouldn't be to get it from a 10 to a 0. In fact, a clinically significant pain reduction is considered 2 points. So a 10 to an 8 is clinically significant. But again, it's going to be patient dependent. So a few other considerations. And our protocol does touch on this. Older patients and or patients with obstructive sleep apnea might be more prone to side effects of opioids. So we do have in our protocol that you might need to adjust the dose. There are some patients who are opioid tolerant. They take opioids chronically, either for pain, for the management of opioid use disorder, or because they use it illicitly. The general principles are of pain management in these patients is to continue the baseline opioid and then to focus on non-opioid analgesic strategies. So that's NSAIDs, APAP, ketamine, and using opioids only as necessary. What about pregnant patients? So when they manage pain for surgery in pregnant patients, when it's when the surgery is non-obstetric in nature, so when it's not related to the pregnancy, it is similar to how they manage the pain in non-pregnant patients with a possible exception of avoiding NSAIDs. NSAIDs should not be used routinely, especially in the early first and late third trimesters because that increases potential fetal effects. Although they do say that a single dose for refractory pain in mid-gestation is likely safe. So, too long didn't read version of managing pain in pregnant patients is just avoid NSAIDs. What about patients who are breastfeeding? They say that anesthetic, okay, and non-opioid analgesic drugs are generally safe while breastfeeding because the medications are only transferred to breast milk in very small amounts. For almost all drugs used pre-op, so perioperatively, there's no evidence of adverse effects on the breastfed infant. They do recommend that you use opioids with caution, especially if you're using multiple doses, and for mothers of infants less than 6 weeks old. Okay, so there's just a few considerations when using pain medications for those different patient populations. Okay, what about NSAIDs? All right. In general, NSAIDs are helpful. All right, so we're talking about ibuprofen or Toradol that we carry. In general, you want to avoid it if they're undergoing a cardiac coronary artery bypass surgery because that can increase the risk of thrombosis. Avoid it if they're having brain surgery, so intracranial surgery because of the bleeding concerns. If they have kidney dysfunction, use it with great caution, or active peptic ulcer disease. Active peptic ulcer disease. All right. Otherwise, using NSAIDs is generally very safe and is preferred. When it comes to geriatric patients, and we define geriatrics as a patient who's 65 years older or more, 65 or more, you want to only give Toradol intramuscularly, all right, because of the possible kidney dysfunction. You also want to avoid NSAIDs for older adults with kidney dysfunction. So, a big question you might ask is, what if there's a fracture? Is it safe to use NSAIDs in patients with a suspected fracture? And there are mixed opinions on this. Some orthopedic docs will say never use it. Some say, yeah, it's fine in certain fractures, but not in other fractures. And I asked our trauma surgeon, Dr. Bernard, this, and I, wanted to know what his orthopedic docs think. And he said, basically, if there's severe bleeding or you suspect severe bleeding, don't give it. He said, but just a simple, non-complicated fracture, NSAIDs are fine and encouraged. So, I know initially when we discussed using Toradol, we put out some training. There was a pretty strong recommendation not to give it if there's a suspected fracture. That recommendation has changed to using it with caution in patients with a suspected fracture. So, if I have an isolated extremity fracture, you don't see massive hematomas forming, you splint it, and you do all of that stuff, then give me some Toradol. The evidence on bleeding or rates of bleeding with NSAIDs, there's not a lot of high quality data comparing Toradol with other NSAIDs. In one meta-analysis, NSAIDs were not associated with increased risk of clinical bleeding. regardless of if the NSAID was administered preoperatively, intraoperatively, or postoperatively. So I think with the recommendation from Dr. Bernard and with what the current literature shows, you can comfortably give NSAIDs for non-complicated fractures.